Bismillah ar-Rahman ar-Rahim. In our previous lectures, we discussed arthritis, types of arthritis, particularly the rheumatoid arthritis and osteoarthritis. Today, we are going to discuss a specific type of inflammatory arthritis known as the gout. Gout affects 1% of the individuals, particularly males are comparatively more affected than females. And the gouty arthritis is the result of deposition of monosodium urate crystals in the joints. It is an inflammatory disease in which there is deposition of monosodium urate crystals in the joint. These monosodium urate crystals are derived from uric acid, and the condition is seen in situations where there is hyperuricemia, elevated level of uric acid in the blood. Now, the uric acid, after losing a proton, becomes the urate ion, and it joins with the sodium ion to form monosodium urate crystals, which are sharp needle-like crystals that get deposited in the joints, and the first metatarsal joint at the base of the big toe is the typical joint that is involved. The deposition of monosodium urate crystals in the joint elicits an inflammatory response. As a result, the joint becomes swollen, hot, and tender, and this is known as the gouty attack. Now let us see that how uric acid comes from and how monosodium urate crystals are formed. We know that the key components of our genetic material, the DNA and the RNA, they are composed of nitrogenous bases that form the pyrimidines and the purines. The pyrimidine is made of the cytosine and thiamine, while the purine is made of the adenine and guanine. When these cells are broken down, the adenine and guanine contains in the purines, they are oxidized to xanthine. The xanthine, which is formed in a stepwise oxidation of the adenine and guanine, is then acted upon by the enzyme xanthine oxidase and is converted into uric acid. Normally, the uric acid is excreted in the urine, and some uric acid is excreted through the fecal route, and the level of the uric acid is maintained at 6.8 milligrams per deciliter. At this level, uric acid is soluble in body fluids. But if the uric acid level exceeds 6.8 milligram per deciliter, and also there are certain other conditions in which the uric acid, the solubility threshold of the uric acid is exceeded and the uric acid crystallizes. After losing a proton, the uric acid is converted into a urate ion, and along with the sodium ion, it will form the monosodium urate crystals. Now, this condition in which the uric acid level is above the defined range, this is known as the hyperuricemia. So, gout is the result of hyperuricemia. The monosodium urate crystals that are formed may get deposited in the joints, leading to the gouty arthritis. Now, the purines which are converted into the uric acid and urates may either be derived from the diet. For example, red meat contains high amounts of purines. Sometimes there is de novo synthesis of the purines from the non-purine derivatives. And in condition when there is excess breakdown of the cells, for example, during chemotherapy, radiation, and other conditions which are characterized by excessive cell breakdown, the nucleotides are released and degraded, releasing the purine nucleotides. The purine nucleotides are purine bases are adenine and guanine. They are oxidized in a stepwise fashion to xanthine, and xanthine is then acted upon by the enzyme xanthine oxidase and is converted into uric acid. About 25% of the uric acid in the gastrointestinal tract is metabolized to carbon dioxide and ammonia by the bacteria by a process known as the uricolysis. 75% of the uric acid is excreted in urine. But all of the uric acid excreted in urine is reabsorbed in the proximal tubular convoluted tubules. Some uric acid is also secreted by the distal tubular epithelial cells, but most of it is reabsorbed by the same distal tubular epithelium, and only 10% of the uric acid is excreted in urine. Now, hyperuricemia or elevated level of uric acid in the blood may be either primary hyperuricemia, in which the cause of hyperuricemia mostly is unknown, and probably there may be a familial primary abnormality in the purine metabolism due to an impaired feedback control. So, these are inborn errors of metabolism which leads to primary hyperuricemia. In secondary hyperuricemia, we know the cause, and it can be caused by increased dietary intake of the purines. For example, red meat and other diets that contain excess purines. There may be increased turnover of nucleic acids in the body. For example, during chemotherapy and radiation, there is exaggerated and excessive cell death. And as a result, when the cells die, the nucleic acids are released, and the purines and pyrimidine of the DNA and RNA are broken down, and the purines that contains guanine and cytosine are converted into xanthine and later on converted into uric acid. Sometimes, as in the previous slide we discussed, that uric acid is excreted in the urine. But if there is a problem, for example, in a chronic kidney disease, the excretion of uric acid or its urinary excretion may be disturbed, and it will lead to accumulation of uric acid in the blood and will cause hyperuricemia. In certain situations, a combination of all these above causes in various proportions may lead to elevated level of uric acid in the blood, causing hyperuricemia. We know that uric acid has limited solubility in the body fluids, and if it is hypersaturated, when there is excess uric acid present as compared to the fluid volume available, automatically the solubility threshold is exceeded, and in this situation the uric acid will crystallize and will form crystals. Up to 6.8 milligram per deciliter uric acid at normal body pH and normal temperature, it is soluble. But a level of 6.8 and above, in this situation the solubility threshold will be exceeded and uric acid will deposit in the form of crystals in the body tissues. Now, hyperuricemia, when there is excess uric acid in the blood or serum, will lead to crystallization, and particularly this type of crystallization will occur in the joints, and specifically the first metatarsal joint at the base of the back toe is involved, and this condition is known as the Podigra, and it is very commonly seen in patients of gout. However, sometimes the urate may get precipitated in the interstitium of the kidney and will lead to the formation of uric acid stones, and sometimes may cause the accumulation of urate and uric acid in the medullary interstitium of the kidney, may cause gouty nephropathy. The precipitation in the subcutaneous tissues, particularly of the ears and in the olecranon and patellar bursa, where there are cartilages and tendons, there may be localized accumulation of monosodium urate crystals surrounded by a zone or rim of inflammatory cells, lymphocytes, monocytes, and lymphocytes, macrophages, and giant cells. And these localized collections of monosodium urate crystals are known as the gouty topi, and they are very specific for the gout. Now, the pathogenesis of the gouty arthritis is that when there is hyperuricemia, excess uric acid present in the serum, the uric acid will get converted into urate, and in combination with the sodium ion, it will form monosodium urate crystals, and these crystals get precipitated in the joints. Once these crystals get precipitated in the joints, they will activate the complement system. These crystals are engulfed by the neutrophil as well as the monocytes, And after phagocytosis or engulfment of the monosodium urate crystals by these inflammatory cells, there is the release of inflammatory cytokines. And the neutrophils, when they are filled with the urate crystals, they burst out and release certain lysosomal enzymes and inflammatory cytokines like reactive oxygen species and other cytokines. Similarly, the monocytes, after engulfing the monosodium urate crystals, cause the release of inflammatory cytokines known as the interleukin 1, tumor necrotic factor, and interleukin 6. And these inflammatory cytokines, they take the condition to a state of inflammation. And this inflammation will damage the joint. And when the joint becomes inflamed, it will be painful, there will be swelling, and there will be severe tenderness. This type of presentation is known as the gouty attack. So we can divide the course of the gout into 4 stages. Initially, there is hyperuricemia in stage 1, but there are no signs and symptoms. In a gouty attack or acute gouty attack, what happens that the monosodium urate crystals are deposited in the joint, and as we saw in the previous slide, it will lead to a scenario of acute inflammation. There will be infiltration of the neutrophils, monocytes, macrophages, and these inflammatory cells will release cytokines which will cause swelling, tenderness, and severe pain. And if the situation is in the first metatarsal joint at the base of the back toe, it will lead to Podigra. The pain is so severe usually that it awakens the patient at night, and even the weight of the bed sheet cannot be tolerated. But most of the times, this gouty attack, the pain and inflammation seen in the gouty attack gradually lessens. And there is a stage when the patient is free of symptoms. This stage is known as the intercritical gout. In this third stage, the crystallization usually disappears, it abates, and most of the crystals formed during the gouty attack, they get resolubilized, and during this stage, the patient is free of symptoms and signs. Now, if there are repeated attacks of the gout, what will happen that ultimately and eventually the inflammation and the deposition of the monosodium urate crystals will destroy and damage the joint, and this is known as the chronic tophaceous gout. The tophi of the gout are localized aggregation of the monosodium urate crystals surrounded by a zone or rim of inflammatory cells, the lymphocytes, macrophages, and joint cells. The most commonly affected joint is the first metatarsal joint or the base of the back toe. However, other joints in the body can also be affected. For example, the knee joint, the ankle joint, and the elbow joint, and the wrist joints. And in that case, the gout becomes polyarticular. When it involves only one joint, this is monoarticular, but if it has got involved many other joints of the body. So we say this is polyarticular. In a polyarticular gout, when multiple joints of the body are involved, ultimately and eventually in the fourth stage are chronic tophaceous gout, it may lead to joint destruction and chronic disability for the patient. Here in this picture we can see the monosodium urate crystal deposition destroying the joint, and which has become swollen and inflamed, and uric acid crystals can be seen in the joint. Now, as excess uric acid excreted through the kidney tubules, or if unfortunately there is some damage in the kidney which cannot excrete uric acid, the uric acid gets precipitated in the kidney, and it may form not only uric acid stones, but if it get deposited in the medullary interstitium of the kidney, it may cause renal damage known as the gouty nephropathy. The diagnosis of the gout is primarily clinical. However, we can examine the uric acid level of the blood. We may see the presence of the tophi, and if we do examination of the synovial fluid, we may see there the monosodium urate crystals. And these are sharp, slender crystals of up to 10 micrometer in length, and usually they are seen within the neutrophils during the process of phagocytosis when the neutrophils engulf these monosodium urate crystals. This is the microscopic appearance of the monosodium urate crystals, which are thin, slender, sharp crystals that can be seen under the microscope. Now, the treatment of gout initially in the beginning of the disease is to treat hyperuricemia. So, what we can do that we may reduce the dietary protein intake. For example, we may avoid red meat intake which contains lot of purines. We may also increase the renal excretion of the urate with drugs known as the uricosuric drugs, for example, the probenecid and salicylates, which are also anti-rheumatic and anti-inflammatory drugs. And also, they act as painkillers. Now, there are drugs that inhibit the xanthine oxidase. We know that the xanthine oxidase is the enzyme which converts xanthine into uric acid. So, the xyluric or the allopurinol can be used to inhibit the activity of the xanthine oxidase enzymes and to prevent the conversion of xanthine into uric acid. Colchicine is another important drug which has anti-inflammatory effect in acute gouty arthritis and inhibits the recruitment and chemotaxis of the neutrophils, and however it has no effect on the urate metabolism, but it will inhibit the recruitment of the inflammatory cells. There is another condition which is known as the PseudoGout. In gout, we know that there is accumulation of sodium monourate crystals formed by the uric acid and sodium in the joints. But in PseudoGout, what happens that there is precipitation of calcium pyrophosphate in the giant cavities, and which will cause calcification of the cartilage, and it has the appearance more similar to that of the gout. And this type of pseudo-gout, which is caused by the precipitation of calcium pyrophosphate and calcification of the cartilage, can be seen during X-ray examinations. However, clinically, it has a similar presentation to that of the gout. However, we can use the plasma uric acid concentration, which will be normal in pseudo-gout and elevated in gout. And moreover, if we do examine the synovial fluid, we may be able to identify the calcium pyrophosphate crystals in the joint. Thank you very much.